It's been a real pleasure over the course of my career to work on GIST. I'm a sarcoma pathologist, and GIST is one type of sarcoma. There's many types of sarcomas, more than 70 types actually, and then a lot of benign soft tissue as well. So GIST is one of the things I work on, but it's really played a very special part in my career. I was lucky enough more than a quarter of a century ago to be working in a place that was sort of ground zero for what was going on with GIST at the Dana-Farber when George Dimitri and Jonathan Fletcher and Chris Fletcher and others were looking at this. I was then lucky enough to get my first job at MD Anderson afterwards and got to work with Bob Benjamin and John Trent and others. And of course, I closely followed the work of Mike Heinrich, who just spoke, along with Chris Corliss, who trained in Boston right before me. It's so this has been a really important part of my career. And a lot of the things that I learned from GIST, since it was sort of the first solid tumor where we had targeted therapy that worked really well, ended up informing the way that I think about other tumors, both in sarcoma and in melanoma and in other tumors that I work on as well. And it's really led me to get to meet a lot of friends, including Nita now, who's one of the leaders of our GIST program here. And I've been able to watch and help support her career in small ways, as she first came here as an assistant professor and is now the chairman of sarcoma medical oncology. So this has been a really important part of my life and career. So this is disclosure information. It's not really relevant for this talk, but I think theoretically we're supposed to make disclosures of all the people that we interact with that are actually for-profit entities. This is just a little bit about me and some of my other interests other than science. Actually, I'm up here right now in this clothing because I had my hip replaced a few months ago, and I'm still doing rehab for this. So I'm kind of coming here directly from Pilates and then from a little bit of cardio tennis that I use for rehab. And I brought clothes to change into, but then I thought, you know what, I'm just going to wear what I'm actually wearing because doctors are physicians. Our physicians are actually people, and this is partially how I do work-life balance. And so, but anyway, this is kind of a sidelight for me of things. Another thing that I'm interested in, I do a lot with theater, both in Houston and also off Broadway in New York. This is one of the early things that I produced. This was a play called Balls that was about the Battle of the Sexes tennis match. Took place in 1973. Actually, right over here, you can look out this window and see the Astrodome. And it actually took place there. It was a tennis match between Bobby Riggs, who challenged Billie Jean King. He was 55, she was 29. She kicked his ass. Some of you may remember watching this. Over 50 million people watched this in the U.S. And 90 million people around the world. And it sort of played an important part with the women's liberation movement and the Equal Rights Amendment that was going on then. And this play was really about how far we've come in terms of the relationship between the sexes, but more importantly, how far we haven't come. And this came out. When this actually came out, we were sort of in the middle of the Me Too era. We actually got nominated for a drama desk. This opened in Houston, but then we took it off Broadway in New York. Unfortunately, we were up against 1984 and Harry Potter and the Cursed Child, so we didn't actually win that drama desk, but it was just good to be nominated. So this is the theater here that I'm on the board of. Stages is the second oldest theater in Houston. Was opened in 1978. We just moved into new space. This is a renovated warehouse. Actually, we moved into it right before COVID. Opened our first play and then closed because of COVID, and then we're closed for a year and a half while we were kind of waiting for the pandemic to occur. But we're back open now and producing theater. This is during COVID, we had to produce theater in different ways. This is something that was supposed to be on stage. This was a play called Pieces of the Moon. And this was about honoring our space program going to the moon, but also looking at something that happened at the same time that people forget was actually happening at exactly the same time, which was the Black Arts Movement in the United States. And these two movements are, really happened at the same time and actually interacted with each other. And we sort of explored this through the person of Gil Scott Heron, who was a musician at the time, who probably was the earliest influence, and rap music sort of is developed as a result of his style of music. And so we tell this story about what was going on, and his most famous piece during this, where he actually talks about the landing on the moon, is a place called Whitey on is a piece called Whitey on the Moon, where he's saying, "Rat done bit my sister Nell, but Whitey's on the moon." And what he's saying is, look, we're in the United States, we have all this wealth and this power, and we're able to take a person to the moon, but what are we doing for the downtrodden portions of society? This is a more recent thing that we did. A season ago, this is the story. This is a play called Plum Sugar. This is something that we produced at Stages. This is about Lauren Anderson, who was the first Black American principal ballerina for a major ballet company in the United States. She was in the Houston Ballet. This didn't actually happen until 1990, so a long time coming. This got really good reviews in the New York Times, and we're currently this will hopefully be touring soon. One of the things that was really cool about this was that we had a lot of the young dancers from the Houston Ballet, where Lauren is still on staff, that actually danced in this, and we literally had all of these people on stage at once. I don't know why this is a thing. I meant to ask them, but then I sort of got embarrassed. It's like, why do you guys all take headshots that make you look like you're naked? But but they appeared, they were completely clothed on stage, and a really wonderful group of young people. So I'm on the board at Stages. My wife is on the board at the Alley Theater, which is the largest and oldest theater in Houston, founded in 1947. And this is a play that we've produced that's actually on right now. It says it's going to close on March the 7th, but it was very popular, so it's open to March the 9th now. And this is the Alley Theater is a much larger theater. They're, at Stages, we have 3 stages that have 100 to 150 seats. The Alley has a big theater upstairs that has 800 seats, and then one downstairs that has 300. This is downstairs, and this is a story about what does it take to be famous. It's told inside of a kitchen. We're actually cooking food on Stages. We had one of our local celebrity chefs, who actually provided, who actually taught, Chris Salazar, who's the chef in this, how to cook. When I went to go see it on opening night, he actually cut his finger with a real knife, and had to put a Band-Aid on it during the play. So it's like real knives and real fun and this kind of thing. This actually kind of a funny part about this. So this person also is named Chris, and so this is Chris Hutchison, and this is actually his wife, Elizabeth Bunch. And those of you that are local, that have been to the Alley Theater, they've been with there for a long time. What's really funny is that they're married in real life, but whenever they're on stage together, her love interest is always not him. And so, this is a great picture of her, with her love interest on the stage, and he's off stage giving all that stink eye. So anyway, with that, let's actually jump into the talk, and talk a little bit about what I was asked to speak to you today, which is about GIST pathology. So here's the 4 things that we're going to try to cover. Number 1 is how do you do pathology? How does that work? What's the information that's in your pathology report, and why is that information there? And is this information actually useful? There's a lot of information in the pathology report. What do we do with it? And then we'll fill in some other hopefully interesting details about GIST along the way. So this is a little journey about what happens to your tumor as it comes into pathology. So this is all set up from MD Anderson, and these are not just these are not just doctors pretending to be doctors in pictures. These are actually doctors being doctors in pictures. And so behind the glass, right here are our operating theaters. The tumor, when it's excised or a biopsy, will sort of come through this window. It gets accessioned into a computer, so we can track who it belongs with. It's then sort of examined by a pathologist. This is actually a breast pathologist doing a breast case, but I'll show you a GIST case later. The tumor is then processed in particular ways, so that we're taking little pieces of it, so that we can look at it under the microscope, but we may also be banking it into a tumor bank so that we can do research. We might do cytogenetics with it. We might send some of it off for molecular analysis. We used to do a lot of things with electron microscopy. We don't really do a whole lot of that, anymore. So the tissue blocks are then loaded into are then fixed in a drug called formalin and loaded into a tissue processor overnight. And then it comes out, and these are these little tissue cassettes here that are each labeled so that we know that, what patient it belongs to and what, piece of the tumor it is. There's a dictation that goes along with this. And so it sort of comes out of the processor, and it's been processed, and it's actually waxy. It's almost, it's been suffused with paraffin, and it actually feels like a piece of candle wax. So then we take the little piece, we put it in a mold like this, so that the piece is actually oriented in this mold. We then make it cold. The hot wax becomes cold and solidifies, and then we actually sort of adhese it to the back now of the cassette. And then with that little cassette, we can put it on this thing called a microtome, which is a really sharp knife, and we can cut these super thin pieces of the tumor here that they're so thin, they're translucent. They're like super thin, almost like tissue paper that you can see through. And this is actually the tumor that we're going to look at in the microscope. But to be able to see it, we have to do more stuff. And so the first thing that we do, this is really clever, is that you can see here that the tissue here is kind of wrinkled. So that's no good. If I were to try to look at that under the microscope and it had folds on it, that would not be great. So we have a way that we can get the wrinkles out, which we actually put it on hot water. And when we put it on hot water, it expands, and then we can pick it up on the glass slide. And then this glass slide is what I'm going to actually look at it on. And you can see here, this one was done, and look, Mom, no wrinkles. So so here's all the stuff. We let these dry out a little bit, and then we put them on a machine that that stains them with two different color dyes. It's pink and it's blue, and then when those mix together, it's purple. So we can see all these great colors that I'll get to show you later that look really pretty. And this process, we can do it by hand, but at this point we have automated sheet machines that do a lot of it because we're really producing a lot of these slides. And then if we ever need to cut additional slides to do other studies, and we'll talk about what some of those are a little bit later, we can do that. Also, all of this material that's in paraffin, we actually, and all the slides, we actually save these at academic hospitals forever. By law in most states, you have to save them for at least 10 years, but at academic centers, we tend to keep them forever. And MD Anderson has blocks going all the way back to when we were founded in 1941. Theoretically, we could pull cases from then. But the cases that we had, the cases that we would have had of GIST back then wouldn't have been called GIST. They would have been called something else that was wrong because we didn't know how to diagnose GIST properly way back in the 40s. So what information is in your pathology report, and what information should be there? Well, this is an addition, and there's newer editions of this, but it hasn't really changed that much, so I haven't updated the slides, even though this looks like, hey, look at that, go, dude, it's like 13 years old. Well, same information, but I should probably change this out. So one of the things that we want to document is what kind of procedure was it? Is this an excision, or is this a biopsy? What is this? What's the site of the tumor? We'll talk about how that's really important for looking at this. The tumor size is really important. Often it's given in 3 dimensions, but the greatest dimension is what we use, is what you'll see that we use for doing risk stratification with this. Most GISTs are unifocal or just one focus of the disease, but they can be multifocal, and if that's true, we want to document it. The GIST subtype, is it spindle cell, is it epithelioid, or is it mixed? This is more important for us as pathologists to be able to know what it looked like so we could recognize it the next time. The mitotic rate is really important, and we count a lot of real estate for GIST because much lower rates of mitoses really affect the behavior than what we see with other types of sarcomas, and we'll talk a little bit more about that. Necrosis, we try to document that. It's not clear that has really any important prognostic information, but we do tend to document that. And then with this information, we'll talk about how we combine this. We can give a risk assessment of how likely the GIST is to behave in an aggressive fashion. It's important to look at the margins. Did we get the entire tumor out? That's very predictive of whether we're going to have local control of the tumor. And then there's some staging that's done. Then staging just basically looks at how much of the tumor is in your body and where was it, right? So is it only at the primary site, and what's the size of that, and did it spread anywhere else, and how many of those, and where did it spread? All right. So then we also do we often need to do immunohistochemical studies, and I'll show you some examples of this in a moment to help us diagnose GIST, and so we want to document that. Very often molecular studies are done. We want to know what the mutational status is. This can be important for some of the treatments that are used, and you got some details with some of that. And then we also want to know, was the tumor, treated before it was removed? Because we want it, when we look at that, we want to be able to estimate, how much treatment effect do we see? All right. So that's kind of what needs to be in the report. Now all of that, depends on actually you're getting the right diagnosis. And when GIST was first, sort of being, defined and separated out from some other very similar tumors, this was a real problem. And one of the things that I did, early in my career was a lot of, and this is actually where I first met Mike Heinrich. Was we were all traveling all around the country trying to make sure that we were teaching pathologists how to diagnose this correctly. Because if you don't diagnose this correctly, there's no chance that you can get the effective therapy that we knew that we had, with imatinib. And so there was a ton of education, and we had some very forward, looking people at Novartis that provided us resources to do a lot of education. And so while we used to see tons of misdiagnosis of GIST, either unfortunately it was usually the opposite. It was people really hoping something was a GIST and calling something a GIST that really wasn't. But we also had GIST being missed as well. Both of those are problematic. I mean, you want to know that a GIST is really a GIST. And so that's, but now I would say that this is actually a very, very well recognized entity by most pathologists, and we really don't see a lot of diagnostic issues with this. Although there's probably some of you in the crowd that can still tell me stories about, well, it took mine a while to get diagnosed. But in general, I think the community pathologist they're certainly much better than we were in the past. So here's an example. Now I get to show you the pretty colors of what I look like, what I get to look at, under the microscope. And you can see here, indeed, there is both pink and blue and a little bit of purple. So this actually, is a GIST, and it has the characteristic staining. We have some kit staining, as you can see here, and some CD34, which is another common marker in this, and then it lacks markers that would be in other types of tumors, such as SMA, which marks smooth muscle, or S100, which tends to mark neural tumors. So just showing an example, here's something that's not a GIST, but still is occurring, in the bowel, and this one has smooth muscle markers like Desmond. And doesn't have the markers that are characteristic of gastrointestinal stromal tumors. So this is a leiomyosarcoma. This is another case that's not a GIST, that has some features that can kind of look like that. It's again positive for SMA and Desmond. Doesn't have other things other markers associated with GIST. Here's the primary tumor, also in the stomach. And then here's a metastasis that occurred for this tumor to the liver. So spreading in the same type of way, tumor that's in the stomach, metastasizing, to the liver, which is a common, pattern for gastrointestinal stromal tumor as well. But this is not gastrointestinal stromal tumor. This is leiomyosarcoma, and this is just it in the liver. So this is the tumor here, and this is normal liver here. Okay. So we have this nice panel of immunohistochemistry that allows us to look at a gastrointestinal stromal tumor and separate it from many things that can look like this. Not listed here, and I need to add I need to add it is another marker that we have that I'll talk about in a moment, DOG1, but this is something that's really evolved over time. So when I was first learning about this and learning how to separate these, this is in the late 90s. We didn't have great markers for this entity that came to be known as GIST, and we could see that it was related to leiomyosarcoma, but it wasn't quite leiomyosarcoma. It looked like it, but it didn't have the same markers. But the main thing that we had to differentiate it from leiomyosarcoma was the expression of CD34. Additional studies, showed that the KIT or CD117 was a good marker for this, and this also, led to our understanding that it was showing similar types of differentiation as a normal type of cell in the body called the interstitial cells of Cajal that perform a pacemaker function, and this is what helps move the things through your gut through peristalsis, through this rhythmic squeezing that sort of moves things through your gut, and so we now have a much better ways to diagnose this. We actually don't use CD34 that much anymore. We use mainly CD117 as a positive marker for GIST, as well as DOG1, and DOG1 is something that was initially discovered in the laboratory of Matt Van der Rijn at Stanford, and he very cleverly named it discovered on GIST #1, so DOG1. So it doesn't have anything to do with canine anything. Matt is Dutch and was just being very clever. So. All right, so now I want to talk to you. So you've seen some other things that are not GIST. You've seen some classic GIST and how they stain with immunohistochemistry, and I want to show you that GIST can look like lots and lots of different ways. Now, to you in the crowd, you may look at this and go, "Oh my God, he's showing us all this stuff, and it's like all pink and it's all blue, so it's all the same." But to a pathologist who spends time nerdily looking through a microscope all the time, these actually look very, very different from each other. So hopefully I'll be able to convince you of this. All right. So here's a fairly standard look for a GIST with these spindle cells. And when we say spindle cells, that means they're elongated like this. And it goes back to an old weaving term where you use a spindle during weaving, and the spindle was an elongated piece of wood that looks like this. All right. So more spindle cells. It sort of almost looks like brushwork. With painting, as pathologists we like to use art and food terms to describe tumors. The art's kind of cool. The food stuff is a little weird, admittedly, but it's well entrenched in the field. So now you can see here. That this looks a little different. So before we had the elongated cells, right? Now we have like these. They're little round ones. They look like little pennies in the bottom of a fountain or something like that. All right. And so these look different, but it's still a GIST. And here's a larger power again, showing these very round cells. So. Here's one again. They're these elongated spindle cells, but as opposed to being in those broad painting swaths like this, it's like little baby brush strokes, like this is what we call a storiform pattern. Here's one here. They're spindle cells, but they're lined up in a weird way so that the nuclei, the blue portions, are sort of lined up together, and this is what we call palisading. So that's a different pattern that not super common in GIST, but we do see it. Here's one where we get these really cool bubbles that we call subnuclear vacuoles, that are very common in gastrointestinal stromal tumor. We see these not infrequently, not always to this degree. I'm showing you kind of an extreme case here to demonstrate the phenomenon. So here's other things that we can see. These little pink dots here, we call these sphenoid fibers. We can also see, more atypia where the nuclei get sort of weird looking. And that they can even become so weird looking so that they look like a much higher grade sarcoma, and sometimes cases like this will even lose KIT expression. And then lastly, here's one where you have these nice little florets. Here where you sort of have like these kind of the nuclei forming petals around the central thing where they look sort of like a little flower. It takes some imagination, but see what you can do. So So in terms of the clinical characteristics, GIST, it really can occur across a wide age range, but there's a peak in the 5th to 7th decades. Males are roughly equal to females. We also have some very, very small lesions, that are incidentalomas, where we discover a GIST almost incidentally, and the most common, and I'll show one of those in a moment. And so the presenting symptoms often include abdominal pain or gastrointestinal bleeding, early satiety, and symptoms referable to a mass. Kind of depends on where the tumor is as to what the symptoms are. Now, these are one of those little incidental GISTs, and this is in the wall of the esophagus, and you can see this tumor here, and I've got it up there, and so it looks like it's massive there, but this little bar here, right here, is 1 millimeter. So if you take your fingers and you put them like this in front of your eye and you open it until you can just barely see between your fingers, that's about 1 millimeter. So that's how big that tumor is. So that's why it's really good to have a microscope, because without a microscope, I wouldn't be able to see that, because these little glasses that I buy for $1.50 on Amazon wouldn't work. This type of tumor is really interesting. This is actually seen in a remarkably, when we do autopsy series, and we and the Japanese have done this because they're very detailed and are willing to do studies like this. You do an autopsy and you literally take thin slices of someone all the way from the top of their esophagus at autopsy, all the way to the other end. A very high proportion of the population will have little GIST incidentalomas like this, there, and they have KIT mutations that are just like the ones that we see in big GIST, and we don't know why, these are so common, but in reality, not very many of them progress to become big GIST, and so there's a lot of people trying to study to figure out, what is it about these, and why do some of them grow big and some of them just always stay small, and it's still, I think, kind of a mystery in the field, but a very interesting one. So here's some more examples of some GIST, of some spindle cell ones on the top and some more epithelioid ones on the bottom, showing some of the mutations. This is old school now, because this is old Sanger Sanger sequencing, with a chromatogram here, showing on the top an exon 9 duplication, and then a PDGRFA mutation on the bottom. And very often, GIST that have mutations in PDGF-RA tend not to have KIT staining in them, but will stain with PDGRF. Here's just the characteristic places that we see these mutations. The vast majority of GIST, the mutations are in exon 11 of KIT. But we can also see, some in exon 9. Exons 13 and 17 are much less common as primary mutations. We tend to see these more as secondary resistance mutations. And then in PDGF-RA, we tend to see mutations in the analogous areas, but unfortunately the exons are one off. So these are the same areas, but what is the equivalent of exon 11 is now exon 12. And then exon 14, exon 18, we don't see these extracellular mutations in the equivalent of exon 9, which would be exon 9 in PDGF-RA. So we don't see that occur there. So this is just an example of the way that we used to do sequencing, with these Sanger. We had to look at this and figure this out by eye, and you had to write all these notes across this and try to figure out where the mutation was, and we would try to do sizing, and it really took a long time to sign these out. Just another example of that. But now with next generation sequencing, we have much better tools. It's much clearer documenting where the mutation is, not nearly as hard, and this has made this process of defining where exactly the mutation is, much easier. Looking again here at KIT staining in GIST, we can kind of see some different patterns of this. We sometimes see really diffuse staining. Sometimes we see more perinuclear dot-like staining. At one point, we thought this might, correlate with the type of mutations that they had, and that's, hasn't been, entirely clear or panned out. So the type of pattern of staining that we see is really not important, except to recognize that both of these are considered positive for KIT. And then here's a KIT negative, GIST that's still staining for dog 1. So dog 1 is really helpful in cases that are KIT negative to pick them up as GIST. Another type of GIST that we can see is a pediatric type GIST. This one, unlike regular GIST, is a little bit more common in females, and we see, not surprisingly, since it's called pediatric, in a much younger population. They tend to be more indolent, but they can have metastases. And what we see with these is they have a very characteristic and distinctive histology, which I'm going to show you here. So this is an 11-year-old female. You can't really see what's distinctive here, but you can start seeing it more here. And this is a pediatric type GIST that's in an adult, and you can start to see that it has these pink strands going through it. And if we look at this at higher power, this is then stroma that's associated. So this is the tumor itself, and this is stroma that's actually not part of the tumor, but is actually induced to grow along with it. And this looks very different than other GIST. And then these also tend to have this type of GIST tends to have metastases to regional lymph nodes, which is unusual in classic GIST. This is a more standard or conventional GIST that has an exon 11 mutation. It has intact staining for this protein called sdh-D, which is a metabolic enzyme. But in these wild type gastric GIST and in the pediatric type GIST, you can see this loss, and it's part of the mechanism for where this tumor is coming from, and so a different mechanism that drives these. So I told you a little bit about some of the factors that are involved in risk assessment in GIST, and we'll sort of go through those a little bit more formally now. We've looked at all kinds of things to try to figure out prognostic factors, but the things that we've really stuck with that seem to be the most important, that are sort of the tried and true. Initially, it was the size and the mitotic rate, but eventually we were able to show that anatomic location was important as well. So this was sort of the first, NIH consensus risk assessment, which some of the folks in this room actually participated in the meeting where this was determined. And basically, it was based on the size and the mitotic counts, and that determined, how likely you were to see aggressive disease. But we know that while the vast majority of GIST occur in stomach, they also occur in the small intestine, and eventually we were able to determine that there was a difference in prognosis based on where the tumors were. Another thing that's important is, while most of these do occur along the GI tract, we do rarely have GIST that don't appear to be connected to the gastrointestinal tract. And unfortunately, since we named this gastrointestinal stromal tumor, when you have a tumor that's not associated with the gastrointestinal tract, it then gets the very odd and unfortunate name of extra gastrointestinal stromal tumor. So no one likes to say that. I don't think anyone loves the name. So EGIST works really well. So if you, so that's kind of the terminology. Those are quite rare, actually. One should be exceedingly cautious about diagnosing a GIST that's not associated with the gastrointestinal tract, because unless it has all the characteristic features, you're more likely to be wrong than right with that. So these are more the up to date guidelines, and again, I should switch the dates, because these are still the same guidelines that we're using today. So now you can see that if the tumor is not in the stomach, but is instead in the small bowel or in the rectum, that smaller tumors and less mitotic activity leads these to be more aggressive. So if you have a tumor that's not in the stomach, in general, it tends to behave more aggressively. So this is what it just appears like. This is one that's in the stomach here, cut in cross section. So the tumor is this part here. This is, I showed you before, the case that was being grossed was actually a breast case. This is one of our fellows who's now on staff with us, actually grossing a gastrointestinal stromal tumor here, and so these are taking the little pieces of it and actually putting in the cassettes to be able to process it. So the things that we're using to look at this, I told you, are the size and the mitotic rate. So what is mitotic rate? Well, mitoses is what cells do when they're dividing. So you have one cell, it then wants to grow. It grows for a bit and then doubles its DNA and then divides into two cells. And so so one cell becomes two cells, and this is how tissues grow and tumors grow. And we can actually recognize when that happens because these are cells that are not dividing. But here, where you can see these little starbursts or these two little, things, two little things here. Oh, this is another good one. So I actually had a professor when we saw things like this when I was training. When we saw mitoses that looked like this, he called these Hitler mustaches. So again, just more visual imagery. But these are what cells look like when they're dividing, and this is an excessively high. This is a very high grade GIST that's actually grown through imatinib, and that's why you can see so many here. And I've just used it for illustration to show you what mitoses look like. But both the size of the tumor, the bigger the tumor is, and the more mitoses it has, both are associated with more aggressive behavior. Now. We have a similar thing that we do where we try to do what's called tumor grading with sarcomas that are not GIST, and here we need a much higher number of mitoses, in order to drive aggressive behavior. And necrosis is important here, and that's why we kept looking at necrosis in GIST, because necrosis is very important for grading in non-GIST sarcomas. But it turns out not to be in GIST. So and then using the size and the location, we can stratify GIST into all these different groups. And if you're obviously if you're low risk, it behaves much better than if you're high risk. All right. So there's other ways to look at this as well. I think the thing that's used very very commonly is the charts that I showed you, but there's also nomograms, so this is an example of one here. It's actually on the website of GSI. I think I actually pulled this one off here because it was just a pretty way to. It's a pretty example of it, and so this one you can actually put the actual true real size in it, and then you use a ruler to measure across these, and it sort of gives you a bit more granular looks at what the probability is of recurrence at 2 and 5 years. There's also, and this is just an example of some tools from Memorial Sloan Kettering that Sam Singer and others have worked on producing there, where you can put in, some of the factors from your gastrointestinal stromal tumor, and it'll give you a prediction of what the risk is of local recurrence and aggressive behavior. So these are some different tools that can be used as well. Now there are other possible approaches and other genomic approaches that we can look at. There are genomic changes that occur in GIST, and Mike talked about some of these with the loss of CDKN2A and other things that can occur. And these also offer some predictive potential for looking at how aggressive a GIST is going to be. But this is the work that's been done here is more experimental and isn't as applied to the clinic. But I'll talk about some of this. There's the mutations that occur in KIT and exon 11 can occur in lots of different places, across the exon. There's been, some work looking at, where's the mutation? Does that correlate with outcome? That's a little bit less clear and is not commonly used. But there are some genetic features, and in particular markers of genomic complexity of how dissimilar to the normal complement of DNA has the tumor become. The more dissimilar, the more crazy looking it is, the more likely the tumor is to behave aggressively. So so here's a case here, looking at different tumors, and if you have the the normal amount of DNA is sort of here in green, and if you have amplifications, it starts appearing yellow and red, and the more you see moving up and down from these from a straight line across there, the more genomic complexity there is. And the more genomic complexity there is, the worse the outcome tends to be in sarcomas in general. And this also holds for gastrointestinal stromal tumors. These are some other studies that have been done, looking at as you see the progression of differences between different chromosomal complements as GIST progresses, that these actually correlate with worse outcome, and that you can sort of categorize GIST into different categories, and that these are associated with better and worse behavior. So these are interesting approaches, but honestly, we usually don't do this kind of complex genomic analysis of GIST. The most common thing that's done with GIST is looking at it more from the standpoint of KIT mutations, PDGF receptor alpha mutations. If it doesn't have those, could it have one of the other rare mutations, or loss of SDHB? So while we can derive these, and some of these look like they may associate well with outcome, we generally don't have the data to be able to look at these signatures. They are intriguing, because they might allow us to take these cases that are very problematic. We have you can have GIST that have a a very good outcome, those that have a very bad outcome, and then we have some in the middle that have an outcome that's kind of in between. And if we could get more information from these, this is probably a mixture of things that are behaving like this and things that are behaving really bad like this. And so there's some evidence that that using these more complex genomic approaches, that we could sort of separate out these into those that are going to behave very well and those that are going to behave badly, and that would theoretically be helpful for what kind of treatments that we want to use. But again, the amount of information that you have to derive from these has been challenging, and these studies have not been well replicated. Sort of heading into the home stretch now, I want to talk a little bit about what treatment effect looks like to me as a pathologist. So what you've seen lots of cases of what the radiology looks like, and the Choi criteria, and how treatment treatment doesn't always initially associated with lots of change in size, but in changes of the appearance of the tumor. But now I want to show you what treatment effect looks like when I look at it under the microscope. All right. So it can be pretty dramatic, just like the radiology is dramatic, right? So here's something, here's a tumor before imatinib, and then here's a tumor, after, just 8 weeks of imatinib, when the tumor was resected. And you can kind of see here, lots of cells, not very many cells. And in fact, this is a much lower power, further away picture, so that I could show that there's lots of real estate that doesn't have, these big cells like this. Now, there are still little cells there, and these are the ones that Mike was talking about that are, that are sort of go quiescent, and that if you stop treating, they can sort of, become, non-dormant, and start growing again, in cases. And I'll show you some better examples of this. This is another example of a treated GIST, where you can see some areas, no cells at all, and then in other areas there's cells here. But these cells, as I look at them, don't look very metabolically active and look like they're sort of inactive. Here's another example here where I'm looking at these in higher power, and these are GIST cells. So you can stain them with KIT or DOG1, and they're GIST cells. They're just not active anymore. So there's no mitotic activity here. They're just kind of hanging out. Even fairly early on, you can see fairly marked effects of imatinib. Even just with 5 to 7 days of treatment, oftentimes the response can occur very, very rapidly, and we can see very dramatic changes in the tumor. But in certain cases, there's also very minimal effect, that's seen, in just a matter of how sensitive the case is to imatinib. So here's an example here of long-term treatment with imatinib, and again showing you that we can still see, as the picture before, things that are still positive with KIT. And then sometimes with long-term treatment, we'll start to see these little nodules that will start growing out again. So these are the earliest, pieces that we see of resistance, where, we've got things covered, but there's something that's, that's now accumulated a secondary mutation, or maybe it had the secondary mutation, all along, and, then we've just selected for it by killing all the cells that don't have the secondary mutation associated with resistance. But it'll start growing in these little tiny areas. And this is, again, one of those little tiny areas that go like this. I mean, this is, only a couple millimeters across. It's a very, very small area, but this is the earliest, visual sense that we can get of resistance. And here's a case here that's a little bit more dramatic. This one had this area here that's with treated tumor, has a mutation associated with sensitivity to imatinib. And is wild type in other resistance areas. And then in this area down here that you can see that's growing and is very cellular with lots of mitoses, has both the primary mutation that was sensitive to imatinib, but a secondary mutation that makes imatinib not able to bind. And so it becomes very, very resistant. Sometimes also with resistance, the GIST can take on different types of cellular differentiation. So sometimes it can show rhabdomyogenic differentiation, so sort of looking like skeletal muscle. And these are some of the markers to sort of prove that. And cases that transform like this tend to behave very, very aggressively. That's kind of it for me. I think we're actually a little bit ahead of time, right?